Students, can you see me, hear me, and see the screen?
Yes, we can.
Okay. Just give it another few minutes. Students who have asked some questions, we asked follow-up. I'm expecting you to report back to us at the beginning of each class.
Hello, Professor.
Yeah.
I just posted my research on the chat.
Okay.
Thank you.
Excellent. Studies have shown that low-dose aspirin is not known to be harmful to fetuses. It is known to reduce the risk of harm, reducing the risk of high blood pressure, preeclampsia, right? High-dose aspirin taken after 19 could cause rare but serious kidney problems in fetuses and can also lead to low levels of amniotic fluid. Aspirin inhibits platelet function and can contribute to maternal and fetal bleeding. Yep. Aspirin crosses the placenta. Hence, the treatment is determined necessary. It is important to limit its use lowest effective dose. Rice syndrome, that's for sure. Rice syndrome, right. Okay, good. And that was a kind of a follow-up to the question of what's the impact of aspirin, low dose and high dose on pregnant women and fetuses. I don't remember exactly, but something like that.
Yes.
Okay, thank you.
Thank you, sir.
Yeah, for young children with fever, I think they want you to use acetaminophen, Tylenol, which is effectively antipyretic, but not anti-inflammatory. So sometimes pediatricians have you switch using some ibuprofen and some Tylenol alternatively, I've seen, to avoid these problems. Okay, let's open the floor for questions and follow-ups from last week. Anna.
So last week I had asked about like if there was any technologies out there that can predict like bacterial evolution for pharma companies to use. And basically I couldn't find anything that like was that specific. I found some like more generic technologies that are being used to look at like the metabolic pathways of bacteria. But there was definitely a lot of research like going into it, because obviously antibiotic resistance is a big thing, especially in this country. One biologist that I found, David McClandish, he's using computational biology to help build predictive models on how the bacteria is evolving. And right now he's in his lab. It looks like he's working on like yeast to start out with. But his hope was specifically to help pharma companies get ahead of antibiotic resistance and be able to see if there's like a certain enzyme or protein that's like more likely to cause the mutations in the bacteria. But yeah, that's what I was able to find.
What was the original question again, Anna?
I was just wondering if there was like any like technology out there that pharma companies are using to like predict bacterial fusion for resistance.
Yeah, that's let's see, someone else asked it. Yeah, there was someone else. Ansia Khan asked the question on the bulletin board. And I would encourage you all to look at the bulletin boards. Students, your colleagues are posing interesting scenarios and questions, and there isn't really a lot of activity. So I think out of respect, it'd be nice if you all took a look at it, the discussions that are posted on Canvas, and see what your fellow students are saying or asking about. I'm responding to some, but not all. But Ansia asked, the introduction of pneumococcal conjugate vaccines for children has brought about significant changes in the epidemiology of pneumococcal disease among HIV-infected adults. There has been an overall decrease in invasive pneumococcal disease, which is positive. there's been a noticeable increase in cases caused by non-vaccine serotypes. What factors might contribute to the shift in serotype prevalence? How can healthcare strategies be adjusted to address the emerging challenges posed by non-vaccine serotypes? What lessons can be learned from this experience in developing and deploying vaccines in other populations? Anybody have any clues as to, well, I did post an answer, my answer, what factors might contribute to the shift to non-vaccine serotypes in the pneumococcal space? Why are we seeing the emergence of new non-vaccine serotypes with increased virulence and antibiotic resistance? Anyone?
Probably due to our overprescribing of antibiotics.
Yeah, exactly, Mama. That's right. That's the primary reason, not the only reason. Part of it is just natural selection. Bugs will be bugs. Mutations happen all the time. Most are not adaptive. Some will be. Those that are selected for evolutionarily, and they become the predominant species in the next generation, as Darwin is always hard at work. So, but I think overuse of broad spectrum antibiotics do apply evolutionary pressure to the pneumococcus and other bacteria. I think that's a major reason for the emergence and increased virulence of non-vaccine serotypes.
Would you also say that it's what is it? Sorry. Would you also say that even though, say, the US is relying less and less on broad spectrum antibiotics for everything, the fact that the rest of the world still continues to overprescribe it and travel incidence goes higher, and we all are traveling and and everything, so we're spreading,
Yeah,
all that. Would you say that's like an also a big factor in how it like spreads?
I think it's a factor. I think that we're increasingly interchanging pathogens around the world by virtue of international travel, cross-border travel. Somebody also posed a question, I think it was on email. I would encourage you to post it on the bulletin board or ask it here so everybody can hear. It had something to do with that issue of in many parts of the world, many of these pharmaceutical products are available over the counter, including broad spectrum antibiotics like amoxicillin and others. I'm not so sure that's a good thing.
Yeah, I know my mom actually brought back a couple on a trip, and I said I asked, how did you get all this, and so they just give it over the counter.
Yeah, I think over the counter availability of antibiotics, broad spectrum drugs, is not a good idea. Clearly in the US, the pediatricians have been overprescribing them for years because they want to give something to an anxious parent. But many times it's unwarranted, and it's certainly led to that problem we just described of non-vaccine serotypes, not just in pneumococcus, but in meningococcus and many other conditions, bacterial conditions, often for viruses. It does nothing at all, but grow resistance to other pathogens. Other points, other follow-ups or questions?
Hi, Professor. I had a question. I know that pharmaceutical companies a lot of times collaborate with like research institutions, academic centers, for a lot of the research. So, for example, in the case of Previnar and Synflorix, how much of that work was done in-house versus like collaboration with like an academic center or an institution?
Yeah, it's a good question. I think that early preclinical work is often done in-house. In vitro analyses, some in vivo work with animals, whole cells. But I think for the most part, all the human clinical trials are done in collaboration with external faculty who serve as principal investigators to bring patients in phase 1 in healthy human volunteers to measure pharmacokinetics and pharmacodynamics. Phase 2, typically in a small patient population for the first time in 100 or 200 patients on placebo or active compound to look for efficacy and early dosing and safety profiles. Ultimately, phase 3, large randomized multi-center controlled clinical trials in hundreds, if not thousands of patients across multiple centers almost all of that work is done in collaboration and for fee. They make a certain amount of money per patient they recruit. There's work to be done, there's time and effort and material. Often blood collection or other samples have to be obtained and delivered, and reports have to be made. So there's a reason to be paying them some kind of a per patient stipend. Typically is how it works. But most of it, essentially most of it, once it gets out of the lab, even the early laboratory work is increasingly done before pharmaceutical companies even involved. They may purchase the royalty or the rights, intellectual property rights to a compound with a licensing fee to a university. So that work may be done completely independent of the pharma company, who then purchases the licensing right, which is one of the big controversies around, ultimately, should pharmaceutical companies be making this kind of money when it is essentially the National Institutes of Health and their 20 some odd agencies, NIH, NIMH, NHLBI, is publicly funded taxpayer money. And if pharmaceutical companies pick up a lead from that, yes, they do put hundreds of millions of dollars into development. Some estimates up to $1 billion to take a product from phase 1 through phase 3 through approval. But it's a gray line as to what is owed the public versus what is a reasonable return on investment for a pharma company that puts $500 million to $1 billion into full development in clinical trials. If the concept came from the NIH funded research in a public university or private university for that matter.
Right. Got it. Thank you, Professor.
It's a complicated question. Unfortunately, there's no great answer.
Right.
All I can tell you is, as we've said from the very beginning, maybe I was out of school that day, but I don't know where else important breakthrough drugs are being developed except for the US and a couple of places in Western Europe. The rest of the world is almost unaccounted for.
Right. And if a drug doesn't work, then the pharma company will just shut down that division and then just move on to the next thing that's hot, right?
Yeah, but they've increasingly they're using biomarkers to look at drugs that are more targeted, so there's less failure. If you make a commitment to go from phase 2 to phase 3, you're making a $500 million plus commitment. You better get that right most of the time. So what is the rate of phase 3 drugs that don't make it to market is less than it was 20, 30 years ago, because many of the drugs today are targeted, genomic and biomarker dependent. Therefore, they're more specific. In the past, there's much greater failure rate in phase 3, which is a big ticket item for a pharmaceutical company. But as to what is fair and reasonable return on investment, well, that's a whole course in and of itself. That you could have lots of passionate people speaking on both sides of that fence. I see both arguments.
Right.
Let's see. Michaela?
Hi, Professor. I just had a question regarding clinical trials, because I believe you just brought that up. I just wanted to know how are they monitored, and like what measures are in place to ensure data quality and integrity?
Well, there are clinical research organizations, CROs, that do that full time. That's all they do.
Mm-hmm.
They have to have, and anytime a drug company has a clinical trial with the FDA, there's tremendous scrutiny as to the protocol methodology. The FDA, as the regulator of drug approval in the United States, as the EMA is in Europe, have tremendous input into appropriateness of study design. And so clinical study monitors, data blinding, statistical analyses, the type of trial that's being designed. Companies don't just do a trial. They have to submit their trial proposal to the FDA for review. Before they recruit a single patient or give a drug, they have to make sure that the drug's been tested for reasonable safety in a reasonable patient population, pharmacokinetics, mechanism of action has to be reasonably well understood. So there's an awful lot of checkpoints along the way to getting the drug into hundreds, if not thousands, of patients around the US or anywhere in Europe that I'm aware of. Very well regulated industry.
Thank you.
You're welcome. Were there other questions? Were any more follow-ups from last week? I know we had a few other points that were raised that I didn't have the specific answer to. So, okay then. I mentioned to you before, just a administrative point. I'm traveling next Tuesday, so I will not be lecturing Tuesday evening. Instead, I'm gonna do the lecture Monday, the 16th, instead of Tuesday, the 17th, so please make a note. I sent out an announcement. There's a couple of students not here tonight. Hopefully they pick that up. But I won't be on the air Tuesday evening. I know that may be inconvenient for you because you've got other commitments. I get it. Don't worry about it.
No.
Just, I will record it. And whoever can show up live, terrific. Others can review it at their leisure another evening or over the weekend. I think after tonight, there are 2 more lectures. And then the final exam. Is that correct? I think that's correct. 3 more total, including tonight. Any questions about that? Again, I would encourage you all to pay some attention to the discussions. I'll show you what that looks like here. You can all see my screen. There are a number of different links to different discussions. You see a few on pneumococcal disease and vaccines, MS oral agents and prognosis. The NSAID discussion had 5. Diabetes from earlier on. PDE5 inhibitors had a few. If there's a blue dot, does that mean somebody's communicating? No. Okay. So do please take a look at that when you can. Any other questions before we go into the lecture tonight? Yeah. This is from David. When a drug passes all clinical trials and has been deemed safe, and later on down the line ends up causing unforeseen effects that can be lethal, what brings that death to the FDA's eyes? Well, certainly, if it's clearly related to a drug that's been approved, sometimes it's hard to tell. But the healthcare provider will report that to the FDA. And things like this have happened. It's not common, but it has happened. Drugs have been removed from the market because, so just to answer your question, anytime a drug company hears about a side effect, let alone a mortality and death, it could be online, anywhere on the internet, Twitter, Facebook, LinkedIn, or whatever. Somebody says something to a sales rep or any company representative at a meeting, it has to immediately be reported to their pharmacovigilance department. All drug companies have that, and they must report every reported, discussed, or mentioned side effect. Certainly, a lethality would be a major event that would require significant regulatory oversight. So there are mechanisms in place for that to be seen. Mustafa asks, can pharmaceutical companies manipulate data? And if so, what happens if that drug has already been approved in the market? Well, you know, we read about fraud all the time in science and medicine if you read the newspapers. Can that happen within a pharmaceutical company? I suppose so. I'm not aware of fraudulent data that's been perpetrated. I'm aware of data that's not been reported that should have been. We talked about that in the Vioxx case. I've seen data that certainly has been questioned. For example, I'll tell you, while it didn't result in a drug approval, it wasted, I think, hundreds of millions of dollars. The amyloid hypothesis of Alzheimer's disease was based upon a fraudulent paper that was retracted in Science magazine, I believe. Clearly cut and paste images of chromatography, things like that, that were revealed upon scrutiny once it was reported. And that led to 20 years of dead end research, as far as I'm concerned. I think if there are changes in amyloid and tau, they're epiphenomena, not etiologic in my perspective. Although, you know, it may have some therapeutic role, but certainly has not paid off. And it was based upon clearly fraudulent original finding. I don't think a lot of people in the field are even aware of that. If you search, you know, amyloid hypothesis fraud, in fact, why don't somebody do that while we're talking? And you'll see the history of that. What would happen if the provider doesn't tell the FDA? No, the physician wouldn't be held responsible. It's not their fault. But so if the pharmaceutical companies, is that what you mean, didn't tell the FDA and they knew there was fraud, that would be criminal. I've never seen that happen. Are there standard adverse event reporting procedures for pharmacovigilance across the board? Or do they depend upon the company and the drug? No, there are standards. I'm not an expert in pharmacovigilance reporting, but you can look that up. In fact, why don't you do that, Ashley? Why don't you next week give us a 1-minute report on standards and methodologies of pharmacovigilance in pharmaceutical companies? That'd be an excellent thing to know more about, because I don't work in that space for the most part, directly. And that I think there are standard reporting forms and standard methodologies. There's probably some of that that's variable and allowed up to the discretion of each company. But every company has a pharmacovigilance department. But this very recent. Well, good questions. Anything else? Okay. So tonight we're going to revisit the vaccine space. And we're going to be talking about the human papillomavirus vaccines, Cervarix from GSK and Gardasil from Merck. In this situation, I worked to support the pre-launch and launch of GSK's Cervarix, where I worked with Pfizer against GSK in the past. Now I worked in this situation with GSK, and at different times, and it's perfectly appropriate. So let's talk about, as we always do, first a bit about the disease state, the unmet need, the pathophysiology. Then we'll talk about the development of these vaccines and then how they competed. And as always, I will tell you exactly what I need you to know as a take-home lesson for this case. And that should be immediately obvious to each of you for every one of these lectures. If you're not clear, speak to your fellow students or reach out to me so that you do understand what the key takeaway points are, because that's the whole reason for this course. It's not to make you experts in pneumococcal pneumonia or human papillomavirus. You're going to get plenty of that as you go on for your additional training as researchers, scientists, clinicians, educators. It's to tell you enough so you can understand how the competition works from a pharmacological perspective. So cervical dysplasia is abnormal tissue growth. And early on, it's relatively easy to treat. And in these graphs, you see the normal cervix, the normal histology, and then the pathological changes that occur as you move towards high-grade precancerous lesions in the cervix. And they develop over time, a lot of time. So HPV doesn't become cervical cancer overnight. They gradually undergo changes to precancerous lesions. It's a little bit like that slippery slope we talked about with GERD And I'll talk more about that at another time, but they become precancerous and then cancerous. It's called cervical intraepithelial neoplasia, CIN. It's the term to describe the initiation of these abnormal changes, classified according to the degree of cell abnormality, low-grade CIN to minimal to high-grade CIN, which suggests precancerous changes. And these cartoons, if you will, show the histopathology on the left of normal to low-grade abnormality, high-grade to precancerous, and you can see where this occurs within the cervix itself. And majority of invasive cervical cancer develops in this flat, scaly surface that line the cervix, as you see on the right side. And this is another view of cervical changes. And more histopathology, looking at what this looks like under the microscope from CIN1-2 to more advanced dysplasia CIN3 to ultimately invasive carcinoma, which can be metaplastic. Yeah, that's what I was kind of going for, Simone. So CIN is kind of like Barrett's esophagus, and that it's not yet cancer, but the cells are not normal, and it's a precancerous condition. As you go from GERD to erosive esophagitis to Barrett's esophagus to adenocarcinoma of the esophagus, you're seeing increasingly cancerous changes that that occur. We're going to talk a lot about this in the last lecture on the Nexium lecture. Another way of looking at this is time to progression. You can go from the HPV infection to CIN1 in a matter of months with some cells involved, to high-grade cervical intraepithelial lesions or CIN2 and 3, where many more cells are involved, but over decades, 10 to 20 to 30 years, to have persistent HPV infection. And I think one of these slides say that majority, 95% clears itself. So to have an HPV infection, which is a sexually transmitted virus, it 90 to 95% of the time clears by itself. And you'll see that in some of this material. The natural history of HPV from the infection, it's transient most of the time. Sometimes it's persistent and then goes down this pathway. And there are different factors that may influence this, but we're not exactly sure. So the incidence and prevalence that cervical cancer is the second most common cancer in women worldwide and a leading cause of cancer-related deaths, particularly in underdeveloped countries. And we'll talk about why that's the case in a few minutes. Looking at the survival rate by stage from the cancer database earlier on, 5-year survival with early stage 0, stage 1A is 93+%. And it goes down, down, down as you develop more cervical intraepithelial neoplasia, CIN1, 2, 3, down to 85% fatality within 5 years with stage 3 disease and stage 4 disease. So quite a serious virus. And really, if you think about this, is a virus, and I believe it's the only known single viral cause of a cancer. Could be wrong about that, but it's certainly one of the few. Clearly, the etiology of the cancerous change is strictly viral. There are no other known causes of cervical cancer. And I'm not sure, there may be some others, maybe there's a form of liver cancer that's also known to be mediated by a virus, I think. But I don't think there's much known about other cancers and pure viral etiologies. Maybe somebody can check me on that. Does the malignant virus strain also clear by itself? the malignant virus strain. I'm not sure what you mean by the malignant virus strain. There's no malignant, so the human papilloma virus isn't the thing that's mutating so much as it is the cervical cells are mutating. The HPV is the HPV is the HPV. It's the, and once you develop, yes, it can recede or clear, but mostly in the earlier forms of the disease. Once it develops into precancerous changes, SIN 2, SIN 3, it's much harder for that to clear spontaneously, but not zero. There are not many, but there are stomach cancers as well. Okay, yeah, I thought there were some others. Non-Hodgkin's lymphoma and Burkitt lymphoma. Okay, so there have been more cancers identified, but not that many. Thank you. But you can see the severity of this disease. If this is allowed to progress, it can be quite life-threatening. So we'll talk about some of the natural history of HPV, that over half of sexually active women and men infected with it at some point in their lives. So clearly, we don't have 50% of the population with advanced disease, cervical cancer, or other forms of infection. I'll talk about those in a minute. So clearly, a lot of this is clearing by itself. And here's the second bullet. Most infections are asymptomatic and transient. 91% resolve without treatment in a couple of years. But you can be continuously reinfected and reactivated. They also cause other forms of sexually transmitted disease, genital warts, etc., and others. Genital cancers, other known cancers are listed here as well, but less clear. And HPV is present in virtually all cervical cancers. So that's an interesting one-to-one relationship. Infection is generally indicated by detection of the HPV DNA. And the serotypes that are most oncogenic are HPV 16 and 18, followed by 31 and 45, accounting for over 80% of cervical cancers. With HPVs, 16 is the most, 54%, HPV 18 is 30%. You do need to know this, okay? You're going to need to know for the exam and for your own benefit what serotypes are mediating significant disease, that HPV 16 and 18. You don't have to know 54 and 13, but just that those two together account for, 60, 70% or more of cervical cancers, those two serotypes. Epstein-Barr virus, yeah. We talked about Epstein-Barr virus also, I think, last time with MS and the VA study. Yeah. So, again, older data by design in 2009, about 11,000 plus new cases of invasive cervical cancer with 4,000 plus deaths. Median age of diagnosis is age 48. And you can see the prevalence among different women in the US. There are other cancer types that are related to HPV infection, as you see on this slide: anal, vulval, vaginal, penile, or oropharyngeal. It's not just cervical, but that's the subject of this discussion, though. But clearly, there are other components to this infection. Okay, I'm going to transition now to the serotype and oncogenicity. But any other questions before we move on? Okay. This is an interesting slide. If you look at the deaths in women per thousand, right? Which is the incidence per thousand. You can see that more developed regions on the left of the zero, less developed regions on the right. See how cervical and uterine cancers skewed to the right. Most of these, like breast, stomach, lung, colorectal, the more common, ovarian, esophageal, etc., pancreatic, are more towards the middle. Why do you think that is? What's going on here? Why is this yellow line for cervical cancer skewed to the right? Yeah, Emily.
Not being the, oh,
Oh, I think it's because you have to follow up with treatment. Like it's not just like a one and done kind of thing.
Yeah, that's part of it. Who else was jumping in there?
it's not being detected early enough.
Yeah, Suraj, that's really the best answer, I think. You're not wrong. But the best answer is that there's just not enough early screening and detection in other parts of the world, in less developed regions in particular, for obvious reasons. But that's really what's driving this. And that's why the vaccine is so important all over the world. Even to some, I don't want to say more important, but the sense of urgency because there's less detection. Here in the US, many women will go in for pap smears, and we'll talk more about that in a moment. But not as much in other parts of the world. The incidence of cervical and uterine cancer at the age of concern, in terms of years of life lost in women, you can see the numbers here are very high in developing parts of the world. And this is just further information about the point we just made. So, as far as we know, HPV is the primary and only known cause of cervical cancer worldwide. As we saw in pneumococcal serotypes, there are many, over 100, greater than 40 infect the genital tract, 13 are considered high-risk serotypes, and they're listed below in order of importance, 16, 18, et cetera, et cetera. The evolutionary tree is interesting to think about. The virus itself has many different potential human targets that mediate different kinds of infection. HPV 611, genital warts, hand warts, these other human papillomaviruses, foot warts, skin and hair, very common, right? But the genital mucosa and cancer associated seem to be off of this evolutionary component related to 16 and 18. But they all probably came from a common papillomavirus core a millennium ago and diverged and ultimately have different target tissues that they bind to. Now, you may recall we talked quite a bit about cross-reactivity in pneumococcal lecture. And because of that, many felt that protection should be type-specific. Protecting against one HPV should not result in protection of infection against another. But there's actually data here that indicate that some HPVs are cross-protective. And I think better data than what I share with you, my criticism, if you will, of the pneumococcal vaccine cross-protection claims of Cervarix, the 10-valent pneumococcal vaccine, that did not contain 19A, but contained 19F, claiming cross-protection against 19A. But I think based upon OPA, remember OPA and ELISA assays that were difficult to understand and didn't really hold up to scrutiny. Here, I do think there is more data that could protect against multiple HPV types, even cross protection claims. But another question is, should the vaccines be different around the world? Well, that becomes a very challenging logistical nightmare. So you'll see in a moment the answer to that question, because wherever you look around the world, for the most part, HPV 16 and 18 are the predominant serotypes mediating cervical cancer, and with some variability, but not enough to warrant the vaccines having significantly different serotypes. Looking at many cells, many cases, you can see here the percent roughly that 16-18 would potentially prevent greater than 70% of cervical cancers almost anywhere in the world that one looked, with 45, 31, et cetera, not insignificant, but much smaller numbers. And this just shows you, North America, South and Central America, Europe and Asia. Those findings held up to epidemiological scrutiny. So that informed the companies in a significant way as to how they should try to build these HPV vaccines. There are some regional differences, but across all regions, you can see here, 16 and 18 was the way to go. And there was some variability, but not dramatic. The serotypes beyond 16 and 18, as I mentioned, serotype 45 and 33 would have been the next to add, but there's a cost benefit calculation done around that. Why is North America grouped with Australia? Don't know. It is odd, isn't it? I really don't know. Have to go back to Clifford et al. 2003 to get the answer to that one if you want. And so the implications for vaccine development to prevent high-grade cervical lesions, which is the goal, you want to know which HPV serotypes are most important in causing cancer, and where you have to get them and to what kind of a patient at what point in their lives, ideally before they are infected, which raised all kinds of challenges. So this is really a discussion as much about culture and parental comfort with having young people, often young women, vaccinated against what was perceived to be a sexually transmitted disease before a young person was sexually active. And that certainly raises a number of sensitive issues with healthcare providers and parents, as you can imagine. We'll talk more about that. But ultimately, the decision was made that there is a pretty clear relationship between high-grade cervical lesion development, as you see here in all, and the cancer. And so that really was the ultimate relationship that drove the development of these vaccines. That women infected with HPV 16, 18, and 45 were really much more likely to progress to serious cervical cancer than those infected with other HPVs. And that's the rationale behind 16 and 18 for sure. And you see what role 45 played as well. These transform cervical epithelial cells more readily as viral oncoprotein formation predisposes these people to high-grade dysplasia that can evade the host immune system. And that's the underlying mechanism of action. So now we're going to look at the perspectives of healthcare providers, women, and others. But let me pause for a second and see if there's any questions about this so far.
Hi, Dr. Sigarnik. Quick question. So I work in a pediatrics office, like I have for 3 years, and this is 100% the vaccine that we get the most pushback about. Like period, it is the most refused one. Is it because of the, like, wait, I don't know if you got into this later either. Is it because of the like implication of sexual activity, or is there like something else like that happens that this became like the target of like anti-vaxxers, or like what is it, do you have any insight as to that? Because it is the thing that 9 out of 10, like not 9 out of 10, but like 4 out of 10 parents will say no to.
Yeah, Brian, it's a really important question. It's a good question. My view of it is that it is difficult to separate the sexual transmission nature of HPV from the fact that it's probably the only cause of cervical cancer. Rationally, one would like to say to a parent, your 13, 14-year-old, 15-year-old daughter, needs to be protected now. One day she'll be sexually active, and it might be too late. We don't know if these drugs attenuate the degree of change. If you take these vaccines after you've been infected, do they attenuate or slow down the rate of cervical cancer change? They might, there's some, but they weren't studied for that. The studies were not designed to answer that question, so we don't know. So it's a tough discussion to have with a parent. That is, imagine the sexual activity of your child is not something as a parent you want to think about. Maybe ever, even when they're older. So imagine thinking about that with a young child. And
Yeah, a
for-
lot of what we
Yeah.
see with that is like they leave, then they come back post 18 and they're their own guard, like they can make their own decisions, then they get it. Is what's funny about it, because then they'll make the
Then they'll
decision
get it.
themselves.
But then they may have already been infected, and most of it will clear anyway. So it's still probably a good thing. The other thing, and I'll tell you, well, this will come up a little bit later, that it's a very awkward, unnatural time to give a vaccine. Our pediatric vaccines, as you know from your practice, are 2 months, 4 months, 6 months, and a boost. You know, think about tetanus, diphtheria, pertussis, pneumococcal vaccines, most meningococcal vaccines, Haemophilus influenza B vaccines, they're almost all given at 2, 4, 6, and a boost at 12. What vaccines are we giving at 12, 13, 14, 15? So we've had to introduce a new time for people to come into the office to get a vaccine. Very difficult to change that kind of behavioral pattern, even for something that is so clearly, related. Now, it also gave the anti-vax community a platform against which to push back with some power, because are you helping young people be sexually promiscuous by giving them the go ahead and have sexual activity early? It raised a lot of religious and ethical and understandable cultural qualms, but it also was a prelude to what we saw with COVID vaccination and others. So it's tough one. Yeah, lots of questions here. Let's jump around. Timothy.
Yeah, so it kind of ties into what he was saying. It's like I know that the cervical cancer is the second most prevalent cancer, and I was trying to figure out, why is it so high? Is it because like the HPV is mutating to the fact that it's kind of hard for the vaccine to keep up, or is basically what you said to people? There's like a pushback with the vaccine, people just aren't taking it, so that's why it's so high and prevalent.
Yeah, I don't really know for sure. We're going to talk about some of the parental concerns at the time of launch, pre-launch, which is where I worked on it. I haven't followed the case or I think there's been actually pretty decent uptake of these vaccines subsequent to their introduction. Somebody could look that up, but I think the rate of coverage now is more than half, if I'm not mistaken. Get Gardasil or Cervarix, I'm not sure which one. I don't think it matters, but we'll come back to that question in a little bit. Jasmine.
Hi, I just had a question because you said that there was a concern for young women, and it seems like all the studies are done with women. So I was just curious why, if they realized that it was something that was sexually transmitted, there isn't testing for men as well.
Yeah, we're going to talk more about that with the Merck vaccine, because that contains serotypes that have more to do with other kinds of STDs and genital warts and things like that. Men absolutely, young men of any age can be carriers, but they don't develop cervical cancer. They can get penile cancer, they can get anal, other terrible things, but not as commonly as women can get cervical cancer. So it's a very tough sell to get a young man vaccinated for Cervarix that doesn't contain the serotypes, and I haven't gotten there yet, so I'm jumping ahead a bit, that doesn't contain the serotypes that block transmission of other kinds of STDs. So Merck's vaccine should have better uptake with young men, and I think it does. Whereas Cervarix really doesn't. If young men were more altruistic and their parents, if everybody got Cervarix and or Gardasil, we could probably do away with pap smears eventually.
Yeah.
Because they'd be complete herd immunity, but we are not anywhere near that at this point in time.
So do you think that, how like some things are becoming more mainstream? Do you think that if HPV prevention becomes more mainstream, more people will be more receptive to it. Because even it was like one episode on like SNL that I saw that they were joking about like having HPV. So I was like, okay, if people are like joking about it as if it's like, so that means it's talked about more often. So if it's talked about more often, would people be more receptive?
It's like build it and they'll come, right? It's like, yes, there's no question there's much more discussion and awareness of the role of HPV in STDs, particularly cervical cancer, than there was before there were vaccines, because there was no discussion. Women, you'll see in a few minutes, young women and their parents had almost no idea that HPVs cause cervical cancer. It wasn't aware, had no public awareness. So there's no question these vaccines have led to a much greater public debate and a controversy for some understandable reasons. Let me go to the chat room here and pick up. Can the other types of cancers cause radiology prevented? Well, we'll talk about that, Amber, in a few minutes. Not so much Cervarix, which is 16 and 18 only, but Merck contains two other HPVs that do mediate other things besides cervical cancer. So the answer is yes. Simran, why do you think there is the age limit to get the vaccine, and why is it ineffective at later older age? Well, we talked a bit about that. We'll talk more. It has to do with, you're better off getting vaccinated before you're infected. We don't know. We didn't study. The drug companies didn't study the effect of vaccination on attenuating progression of SIN1 to SIN3 to cancer. What determines the age at which the vaccine should be administered in order to be the most effective? Before you're infected, before you're sexually active. Is there even an age where it would be considered more or less effective? No, same thing. Najma asks, culture for sure plays a role in parents choosing to not have. Yeah, no doubt. I've heard that quite a bit, and it's a challenge, and it's one that you can get your head around. Even if you're not a parent yet, you can imagine that's a very challenging discussion. Prostate cancer, I'm not aware of that. I'm not aware of HPV's role in prostate cancer at all. I don't think that's oral, anal, penile. Yes. Yes. Okay. By virtue, Ashley, did you go already?
No, I Simone kind of had no, Jasmine had a question kind of similar to mine, but I just wanted to confirm. It sounded like that men and women are both prone to getting like HPV, but women are more susceptible to it. Is that correct?
Well, because they have a cervix and men don't.
Yeah. But like I guess like because they can be carriers of it, but not necessarily.
Sure can.
Yeah.
They sure can. And they do get other HPV genital infections that can be quite serious.
Is that like the percentage of that be similar to like a woman getting HPV? Like is it
I'm not sure. Why don't you do a little research and fill us in next week?
okay. Oh, sorry, go ahead.
I think I might have some slides on that coming up. I'm not sure.
Okay. I did have a question based on the age. I know someone had brought up as well. I know some doctors have suggested that once a woman is about like 27, that's like the cutoff for getting the vaccine. And I'm not sure if that's because your body is like, I don't know, there's a lot of changes going on, or if it was more so just like insurance companies wouldn't cover it past that.
Who knows? Women who get cervical cancer who were infected in their late teens and early 20s develop cancer in their 30s and 40s. Mm-hmm. So if you get a vaccine after you have SIN1, SIN2, even SIN3, does it slow down the conversion to cancer? Not been studied. Mm-hmm. And I'll show you why. These studies are enormous. You need tens of thousands of patients and global, because you can't, this has to be worldwide, because there are cultural differences in sexuality and sexual mores that determine how these things, what the journey is for these people. So you can't just go with US data or European data. It's not fair. So it's a very complicated question that requires massive numbers of patients in multiple cultures. And that's a big undertaking. But there's no data that shows us why a woman at 27 would be why it would be effective. We've never seen an attenuation of a cancerous change by a woman pre-infected. It's never been done. Doesn't mean logically you'd think it would work. I mean, intuitively it makes sense. Why would it not? But that's just speculation.
Right. Thank you.
Alu?
Hello? Oh,
Yeah.
hello, can you hear me?
Yeah, hi.
Oh, yeah. So, yeah, when you were just speaking about data, I had a question because I'm from Nigeria and I've lost a few people to cervical cancers. And at least 5 of them were getting IVF treatment. So, when you mentioned that, I always wondered if there was a relationship between people trying to get pregnant and IVF with cervical cancers. But there are no studies on that online.
I've never seen any data on that.
Hmm.
You're dealing with an age of a population where fertility and infectivity are kind of concomitant issues, aren't we? So it's very difficult to tease them apart. That's why the clinical trials had to be done with very rigorous inclusion and exclusion criteria. Women of this age, men of this age, not this age. Because if you enter more variables, you don't know, you can't determine what cause and effect might be.
Thank you.
It gets complicated real fast. Is there a minimal age? If you look up the label, I think there's a recommended age. Can somebody, I could do that while we're talking. If you look up Gardasil, what is the recommended age? Here's the Merck product insert. 9 through 45 years of age. So that's pretty wide now. Now it's Gardasil 9, so they've added more serotypes. I might even see it has multiple serotypes now. So things have clearly evolved since the introduction of these agents. That's always important to know. So it's a much longer age range with many more serotypes. Gardasil 9. Now let's see what Cervarix is up to. Still straight 16 and 18, as far as I can see. Let me see. Yeah, I think it's still, so we haven't evolved the vaccine from what I can see, just taking a quick look. Recommended age 11 to 12. After 9, 11 to 12. 10 to 25 recommended. And I'm going to show you the studies now that they were done in younger women. So physicians understood the significant health risks for women in particular. Generalists and specialists had differences in knowledge of primary care doctors versus OBGYNs or pediatricians. Gynecologists clearly had the greatest understanding of HPV types classified as high risk. But they tend to speak to the patients in very general terms about STIs. And primary care doctors tend to talk in generalities about well-being and pregnancy. Gynecologists had a preference for high efficacy vaccines that were safe. Women, we surveyed women to understand this, they'd heard about HPV but don't know a lot about it. They were shocked to learn that it's a virus that can cause cervical cancer. Once they knew that, they wanted more information and they wanted the best protection for their children. Not a top of mind health concern, cervical cancer, even for women who had a history of abnormal pap smears. Breast cancer, much higher awareness, obviously. When they would have gynecological health visits, they're talking about menstruation, menopause, birth control, other STDs, STIs. In a gynecological visit, it wasn't made clear, we found out, that yes, it's prevention and health promotion, but most of the discussions with younger women about birth control, for older women, is about pap smears and mammograms. The pap smear itself wasn't much discussed most of the time. That was fairly uncomfortable. A vague purpose of a pap smear, some kind of reproductive cancer. Very few mention cervical cancer specifically because it's uncomfortable. It could be embarrassing. Considered, it makes people self-conscious. So to minimize patients' anxieties, we found that physicians limited the information they shared. Physicians knew what a pap smear was for. Cervical cancer prevention, period, full stop. Patients didn't really understand it. It's screening for STIs. No, not really, not directly. They didn't share much information. Most women had never heard of HPV. For these vaccines, nobody was talking about this. And little communication was coming from the physicians. So there was a critical need for this kind of information. Once they understood it, they were willing to endorse the use in women of this age range. And clearly, when physicians were surveyed, who would they recommend it to? It was that 15 to 40 year group. You can see that's roughly the age range we're talking about. Women, once they were made aware, responded favorably to the concept of a protection against an oncogenic HPV. Interest increased with the perception of that relationship. They were concerned about the safety and effectiveness, understandably. Culture, religious affiliation are factors, but they want to keep their children safe. But most felt 10 to 14 were too young to receive the vaccine, as was mentioned earlier, to protect against a sexually induced transmitted disease that could lead to cervical cancer. 18 and above, okay, but often too late. So you can see therein lies the dilemma. Is HPV the only cause of cervical cancer? It is, as far as we know. So every single case of cervical cancer is an HPV serotype. Breast clearly have better marketing. Well, perhaps. Can women still get HPV if they have a full hysterectomy? They can get HPV, but they can't get cervical cancer if you've had a hysterectomy. You could get infection in other potentially locations, anorectal, etc. So you can see why this case was as much pharmacology as it was sociology and psychology and acceptance and education. So that's why I offered this case among the hundreds I could have called out and used. This one to me spoke to the complexity of the human factor of awareness and education. And women and we're willing to consider this, certainly if you look at this 1 to 10 Likert type scale, if they understood it. Certainly physicians were all over this. So it's a concern. Once they understood it, they understood the need to immunize themselves and their daughters. There was a limited understanding of the relationship between HPV and disease. They did not link the two together at all. But once the vaccination was explained, it made some sense. And I think the uptake today is much greater than it was certainly in the first year or two post-launch. So along came GSK's HPV vaccine. Their strategy was the best possible cancer vaccine for women, focusing on the most oncogenic HPVs, which are 16 and 18. And they used this virus-like particle, which was new at the time, a recombinant protein resembling the intact virus, but could not convert to the active virus. It's not infectious. And they used an AS04 adjuvant, as they do today in most of their vaccines, that boosted the effect. And it was a 3-month schedule, three injection schedule, 6 months apart. well, 0, 1, and 6. Induced neutralizing antibodies, that was demonstrated preclinically that they did. And, how long would the protection last was unknown at the time, because they didn't have long-term data. The adjuvant, the ASO4 adjuvant, would boost that durability. And then they knew it was safe and tolerable because they've done it before. So a broad range of ages for the prevention of human papillomavirus infection. And they had to have pap smears as part of their surveillance around the world. And they did decide, for the reasons we mentioned earlier, that 16 and 18 were the two serotypes that were going to be most important in avoiding serious disease. And that's in fact what was contained in Cervarix. And they showed that both the GSK and the Merck vaccines, which I'll show you in a minute, prevented persistent infection correlated with not developing SIN2. So obviously that will prevent SIN3 and metaplasia and cancer. So they looked at the conversion through pap smears in these people in the studies, these young people in the studies, of the conversion of SIN1 to SIN2. And that's a kind of a hard and fast endpoint that could be measured. Is there a test to see if the vaccine is effective? Well, the test that I just mentioned was the ability to, there's no like in vitro ELISA or OPA type. Well, there are. We'll talk about that in a minute. But in the clinical trials, they looked at the inhibition or the attenuation of SIN2 by pap smear. This shows some of the evidence of cross protection that I found to be more rigorous than the pneumococcal pneumonia case. And you can see here the 16 and 18 serotypes as to their cross protection against for 16, 31, and 52 looked pretty significant, that the vaccine efficacy was 78% essentially, and 75% is serotype 18 against 45. And if you remember what I said earlier, 31, 52, and 45 are the kind of the next level, most frequent serotypes involved in mediating both cervical cancer as well as some other forms of STDs. So I found the data to be more compelling in this situation. That the vaccine was safe and well tolerated, good antibody response with high titers, with a 91% protection against 16, 18 induced infections, and some cross protection against other secondary serotypes of HPV. And the development studies, as I suggested to you earlier, indicate as enormous. 25 countries, 35,000 subjects screened, 25,000 enrolled. Imagine the cost of something like this worldwide because of the nature of this condition. And they had a couple of years of follow-up, but not now. We have more than 15 years, and there's great durability of these vaccines. There's no evidence they need to revaccinate at this point in time. And they looked at what age populations, et cetera. In the efficacy studies, GSK did double-blind, randomized, controlled, multi-center, multi-country, and tens of thousands of women. So this was a very comprehensive database with a firm pap smear verifiable histopathologically demonstrable SIN2 or beyond as a primary endpoint. So you attenuate disease progression as a definitive endpoint in these clinical trials. Janet asks, are there any groups of people who should avoid getting vaccinated? If so, what alternative prevention methods are available? I don't know. I guess if someone's allergic to any of the ingredients, who should avoid getting vaccinated. What are you thinking there, Janet? Like who? I'm not sure who that would be. Of course, they've continued to study long-term the durability of effect around the world. And those studies ensued over a number of years with high efficacy. And this is the profile. And this was the vaccine. Approved in October of 2009 as a bivalent 16-18 serotype HPV using virus-like particles that's a recombinant with the AS04 adjuvant to boost the immunogenicity indicated for women at the time, 10 to 25. I think that's been broadened over 3 doses. At the time, 6+ years. I think it's over 15 years now. Allergies, let's see. Any people with allergies or past medical history? Well, I don't know what medical history would preclude them from getting the vaccine. Allergies to those ingredients, certainly. Immunocompromised, I don't think there's any contraindication for people taking steroids or TNF inhibitors or any immunomodulating agent, since this drug doesn't have any demonstrated immunomodulatory properties or effects. You can look at the product label to confirm that. But I've never heard of that. When we look at the Gardasil also showed very high efficacy in preventing precancerous changes, the Merck vaccine. There were 4 subtypes in their vaccine and showed some cross protection as well. The Gardasil Merck vaccine approved in 2006, so earlier than Cervarix by a couple of years, was quadrivalent. That included 16-18, the most common cervical cancer serotypes, but also 6 and 11, which mediated protection against genital warts. So really a lot of the pushback, GSK with Cervarix was really trying to avoid, I think, that this is a STD vaccine, whereas that's because it just targeted a cancer and nothing else. They were hoping that would avoid some of that debate, but it really didn't, in retrospect. Merck, which I think has the biggest market share today, purposefully included known HPVs that mediated things other than for a cancer, like genital warts. And so it was clearly stamped as a STD vaccine. And I think there was a lot more pushback on Merck, but they all got washed with the same brush, they painted with the same brush. They're all STD vaccines on some level. But really, Merck's was much more clearly associated because it contained more than just 16-18 serotypes. 6 and 11 are not mediating cervical cancer at all. Also 3 doses. And they were both highly effective. Price was not an issue. Covered by most payers. And regulatory bodies and national organizations like the American Academy of Pediatrics, family physicians, OBGYNs, they all supported it. Now, the national organizations also said it's clearly going to be most effective if given for first sexual contact. That requires reaching, in particular, women at a fairly young age, which raises a lot of cultural and ethical concerns. So that was quite a battle. You can have the vaccine. They didn't contraindicate it or block it for people who tested positive for HPV, who were already sexually active, but the efficacy wasn't tested in that patient population. That vaccination provides protection against infection with HPV types not already acquired. No therapeutic effect demonstrated on already present HPV infection or associated disease, but it can be recommended because maybe it does work. How long do these vaccines last? Well, we have data now since '06, right? '06 to '09. So that's a long time. Certainly over a decade, 15 years. I see that for both vaccines, there are an amount of years of demonstration of protection, right? Is there a booster that is offered after those years like it was done? I'm not aware of that. And again, Amber, why don't you look that up? Because clearly, Gardasil has many more serotypes in its current formulation than it did back then. Just like we saw Prevnar go from whatever, now it's 20 serotypes from Prevnar 13 to the original 7. So if you could just give us an answer to that, that'd be really interesting to know. I'm not aware that women or men require a booster. Thank you. Jana, is your hand still up?
Yes, I have a quick question. It was from the previous slides. So in case somebody gets a reinfection or gets reactivated, would they have to get another vaccination? And if so, how long does that last, like protection wise?
I don't think so. So if somebody was already infected and got a vaccine, infection cleared, but they got reinfected, there's no recommendation to revaccinate. As far as I know, and I think somebody just chimed in, we'll check on this. I think it's, you get the 3 and you're done.
And would there be any other steps they would have to take after reinfection?
Well, everybody still needs pap smears, women.
Correct.
Because there's no herd immunity that would wipe out if every single young person, male and female, got HPV vaccine, theoretically, not going to happen in our lifetimes. Theoretically, but after maybe a generation, you wouldn't need there'd be no cervical cancer. If this is truly the only cause, that assumes it's 100% effective, which they're not.
Right. Okay. Thank you.
So pap smears are not going to go away in your lifetime. Even if every patient you ever see is protected by HPV vaccines, they still need pap smears. For the reasons mentioned. That's not 100% effective. And it may attenuate more severe disease. I hope that's shown and proven someday.
Yes.
You are previously infected or reinfected. But I don't know that you really need, I've not seen, again, my involvement's back in 2009. So I don't know. I represent these cases at the time I worked on them. I drove the medical strategy for GSK on Cervarix. Talking about the fact that it's only 16 and 18, it's not an STD vaccine. It's a cancer vaccine. Now that was our story. Educate women, educate their parents, educate doctors, PCPs, OBGYNs, pediatricians. Did the surveys, those were my numbers. But the field's evolved. And that's the case with every one of these lectures. I don't really follow I'm not a specialist in any one of these areas. I'm a pharmacologist by training. My interest is in how we use pharmacology to drive product differentiation in competitive landscapes. That's my point of teaching this course. And those are the lessons I want you to learn.
Absolutely.
Because there are going to be new vaccines for new diseases that we're already seeing today, but you're going to see many of the same issues: serotype coverage, cross protection. How is the information parlayed and leveraged? Who's saying it? Is it credible? Those are the lessons I want you to learn, because you can use this for something that will happen long after I'm out of this business and you're still working.
I'll definitely continue researching that.
You'll remember, I heard it here. Dr. Cervical told me,
Yes,
what he's doing today. Is he still alive?
I'll check on you, no worries.
I'm never retiring, by the way. Just so you've heard that here first. This is on recording.
I did.
I will never retire. This is too much fun.
Thank you.
You're welcome. Yeah, they're both administered roughly the same way, the same time. The expenses are covered by various insurance companies and the public domain. Safety and side effects, they're really relatively safe. There's never been any terrible signals that we would be worried about. So none of these have been pulled from the market. But there was controversy at the time. You can see the dates here. Michigan enacted legislation to mandate vaccines. That didn't hold up so well. Texas issued an order that girls be vaccinated. That didn't hold up so well. That's not the Texas of today. The societies, the medical societies, were advocating but not making them mandatory. So in summary, clearly, human papillomavirus is a common sexually transmitted infection and is probably the only cause of cervical cancer as far as we know. They're safe and effective vaccines. The routine vaccination of young girls, supported by the CDC, by the Accrediting Council of Immunization Practice, by the American Academy of Pediatricians. Catch-up doses can be given later on. Males are offered the vaccine, particularly with Gardasil, because they do get infections from the other non-16 and 18 serotypes. Parents are generally accepting once they learn about it, but in some parts of the world, that's a much tougher sell, and we understand culturally why that would be problematic. The key issues to think about, the things I'm going to look for you to feedback to me in the exam, will be a 10-point question, as there will be for all of these lectures, in essay form, keeping it short, about the nature of the HPV infection, 16, 18, and the others, the difference between Cervarix and Gardasil in terms of its coverage, what was Merck trying to do with the other two? Clearly, that was directed towards the males. What's the story with persistence and clearance, serotype coverage, bivalent versus quadrivalent, the cross protection claims, and the question of pap smears and herd immunity, which really isn't going to happen anytime soon. You can see that the sales of Gardasil dwarfed Cervarix in its lifetime. And I assume that continued. Some of these were projected numbers, but it was three times the sales, but not zero. Cervarix held its own, but possibly if you think about a winner and a loser, it's hard to say you're a loser to $600-700 million a year product, but $2 billion a year product is another league of its own. And so that's it for this lecture. I hope you found that interesting. I think it raised a bunch of issues that we haven't discussed before. Jasmine asked us the age range for younger ages because the body would have a better chance of clearing infection. I suppose that's true. I think the younger age range was to get men and women before they were sexually active and became vectors, and then you're trying to attenuate pre-existing disease rather than blocking new onset. But having a younger immune system is probably helpful too. I think because it will ensure prevention. Yeah, as children of that age are generally not exposed to STIs. Yeah, one would hope. Agreed. Okay. Anything else before we close out for tonight? Okay, students, again, we've got 2 more lectures next Monday, not Tuesday. Please remember, I won't be here Tuesday, but Monday. If you can make it, great. If you can't make it, just check the cloud recording on Canvas. It'll be there within a day or two. But you do need to listen to it because it's going to be on overactive bladder and the launch of the anticholinergics, which is an interesting lecture. The earliest form of pharmacology were anticholinergics. We'll talk about that in relation to overactive bladder. And the final lecture the following Tuesday will be on GERD, adenocarcinoma, and the launch of Nexium from Prilosec. And then there'll be the final exam. Okay, any other questions? You're most welcome. Okay, everybody. Oh, Esther raised her hand. Esther.
Oh, sorry. I just wanted to know, is there going to be a review for the exam or no?
Not by me.
Okay.
You guys can get together and do whatever you want.
Okay, thank you.
But if you have questions, certainly shoot me an email or post it on, better yet, post your questions on the bulletin board on Canvas so everybody can see it.
Okay, sure.
The final is on the 1st. I think so. Let me
31st.
yeah, hold on a second. Let me look at my calendar. Yeah, so the 16th is the next lecture, the 23rd is the 24th, sorry, the Tuesday is the last lecture. The 31st will be the exam. And I'll post it just before 7 o'clock. I'll come online. You don't have to, I mean, I'm not going to be talking to you. I'm not giving you a lecture. You'll just complete it on your own, send it back to me that evening or the next day, or like I said, it's for you. Do whatever you think is best. I don't really care. Open book, closed book, take a day or two. If you have more than that, you gotta let me know, because the clock is ticking at that point. I have limited time by statute from the university. So, but again, don't sweat it. I've been very clear and candid with you. There'll be no surprises. I think I told you all, recovering from Achilles tendon surgery on the 27th, but I'll be conscious and not walking, but able to partake and answering general type questions. But if anybody is, whatever accommodations you need, just take. Okay, you're all adults, you're all professionals, you're all gonna be doctors. Just get it done. Leave me alone.
Thanks so much.
Will the grading be will the grading be like based on how correct it is, or like?
The grading is on my own assessment of whether you got it or not.
Okay.
There are specific things you need to know. For example, COX-2 specific inhibitors, Vox and Cervarix. You need to know the difference between the constitutive and the the stimulated pathway, and the different mediators, and where COX-2 inhibition, why COX-1 is gut protective and COX-2 is inflammatory, so by knocking out COX-2 but not COX-1. You know what I'm saying? You've got to know that. That's the basic concept. The PDE5s, you got to understand the difference between those agents and why. Is it just Coke versus Pepsi? No, they're different. They bind differently in those assays, and those assays have meaning. Look at the dose response curve that I showed you for cyclic GMP accumulation in human corpus cavernosum of vardenafil versus sildenafil. That tells you everything pharmacologically about its potential, why it works in tough to treat patients. That's the kind of level of information. You don't have to be experts in any of these diseases, but you've got to know the pharmacological pathways upon which those differentiations were based. The difference between an A and a non-A in this course are students who are specific about the pathways that were attenuated or potentiated or whatever it was, and those who are not. For the pneumococcal vaccine, you got to know about 19A serotype and tell me specifically about it, and the cross protection debate. I've been very clear about that. And I always have a student or two who push back and say, "Why did I get a B?" Whatever. And I'll take you through that, but trust me when I tell you, I've done this for a long time, and you can't fool me. These are my cases. I built these. I'm the medical strategist that was behind these. And if you don't know the details, you don't know the details. So I want you to know the concepts, but please show me that you understand the pathways. Everybody get that? Because there's always going to be one or two students who are going to have a long face and not going to get an A because of that. And I'm telling you right now, if you don't talk about those details, you won't be getting an A. Michelle.
Sorry. Hi. So do you want us to list every step in a pathway?
No, just the one where the intervention is critical.
Okay.
Like for the PDE5s, you got to know that they what do they do? The Levitre agracialis, they block the degradation so they cause a net accumulation of cyclic GMP. They block the phosphodiesterase enzyme. That much you have to know. But you don't have to know every testosterone goes to this, goes GTP to GMP. No, I don't.
Okay.
No, you just need to know where in the pathway cyclooxygenase works, right? So it blocks that conversion from the arachidonic acid to the prostaglandins, and the pathway converges PG, the inflammatory versus the gut protective, and why one is considered PGE1 sparing, therefore gut protective, that kind of stuff. So just pieces of the pathways that are relevant to the strategy. I only care about your understanding of the strategy, but you can't tell me you understand the strategy if you don't tell me where in the pathway that happened. So there's a little bit of detail you do have to know for each question, but I think I've been very clear with you about what is that thing I'm looking for. And then I'm asking you to talk about it. It's not just telling me the pathway isn't the whole answer. That's half the answer. The rest of it is, why does that matter in this disease for this drug? How did that differentiate the compound? So I'm trying to help you understand that the very same principles are going to apply for the rest of your lives, for the rest of your working careers. That everything I touch today is based upon similar principles of pharmacology and differentiation. There's different drugs, there's different diseases, but it doesn't matter. You're going to learn a way of thinking. So know the specific piece of the pathway that's relevant for you to elucidate and talk about how that was differentiating. Now, drugs that should be Coke versus Pepsi are not at all Coke versus Pepsi. Okay?
Thank you.
All righty. Okay, students, have a good night, and I'll see you Monday, the 16th, if you can make it. If you can't, no worries.
Thank you, Professor.
You're welcome. Bye-bye.